I now invite Dr. Parikshit Gogate for his topic, Recent Advances in Low Vision and Rehabilitation. Dr. Ashwani, topic of your interest.
Good afternoon, Dr. Radharaman sir, Dr. Sharad Babu sir, Dr. Pallavi Sinha ma'am, Dr. Rajan Anand sir. At the outset, I would like to thank the scientific committee for giving me this opportunity. This is not something that we ophthalmologists usually like to hear, and very few of us actually do. But then low vision and rehabilitation has to be an integral part of our practice. Because, yeah, now you can start the timer. And because when this is a quote by Swami Vivekanand, how developed a society is depends upon how it treats its weakest members. And the blind are some of our weakest members. And I have put a picture of Adolf Hitler, I should have put one of perhaps Churchill, is that till 1925, if you will look at the first 20 years, the Nobel Prize winners in the English-speaking world and the German-speaking world, they are almost the same. But then the German-speaking world fell under the pall of a leader who perhaps believed that those who are weak, who are useless, should not live. Then the great setback that it caused to them, it took almost 50 years for them to come out of it. We all know what low vision is and how that is classified. We know the causes of that. We know the prevalence of it. Every 5 seconds, one person goes blind. But then we have in our OPD patients of glaucoma, of retina, of end-stage disease who are blind. But there is still so much more. Their life still needs to be led. So the goals of rehab is, one, to maximize function, to enhance a patient's potential, to increase independence, and to improve quality of life, which is what we try to do in our low vision center. So one of the few things that we should learn is how to lead a patient who is blind, and this is something our OPD, OT staff should know, our receptionists should know. We all know about hand magnifiers, how they can be used for viewing near objects. There are stand magnifiers, reading from books, newspapers, and nowadays you get them in so many different shapes and sizes. And thanks to technology, you can order them on Amazon. So there are illuminated hand magnifiers, stand magnifiers, pocket magnifiers. And everybody nowadays wants to read, they want to look at their mobile phone. Similarly, for distance, we have telescopes, and telescopes are used to look at bus numbers, to cross streets. If a child sits in a classroom, to see the blackboard, traffic signals, road signs. And again, they comes in various shapes and sizes: binocular telescopes, clip-on telescopes, handheld telescopes, again, spectacle-mounted ones, outreach ones. So there are so many that are available which were not there when I was doing my residency about 30 years ago. And it's not just optical devices. We have non-optical devices. They are used to enhance the visibility of the retinal image and optimize the use of optical devices. So simple things like a reading guide or a signature guide, because in many senior people, they want to sign a check, or they want to put in their name. Or if an old grandmother wants to do embroidery, there are needle threaders. Then there are notexes where you can actually put in a currency note and it helps you identify that, because for the last 15 years, as per RBI regulation, even the Indian currency has special notations that even a blind person can look at it. That is why notes come with different sizes, they come with different tints, so it becomes easier. In that respect, perhaps the dollar is considered the least disabled-friendly currency, because all their notes from $1 to $100 are the same, which is not the case for others. Then there are absorptive lenses. A lot of people, they have oculocutaneous albinism, or they may be having retinal disorders, where if you give a specs that enhances contrast, reduces glare, eliminates UV light, it will help them. There are mobility assisted devices. There is a long cane training, and they can be used to search the ground ahead. It warns you of obstacles and drop-offs. In fact, nowadays in the smart city project that the government has bought, if you look at it, even the streets, the pavement is done in such a way that you can make out whether now there is an intersection going to come, whether this road is going to end and another road is going to stop. So all of this can be done using a white cane. So this is there, a part of life in the Western world, but it is coming to us also. So mobility devices, when I was at Moorfields, we would be so surprised to find that in our glaucoma clinic, people would come with a guide dog. So they would use the London Underground, they would change to tube stations and then come to Moorfields. And those dogs were allowed and they were extremely well-behaved dogs. There are also nowadays portable strong torchlights, there are night scopes. But what has actually changed the game is assistive technologies in the last 10 years. So this overcomes the limitation of optical aid like reduced field of view, working distance and contrast. And it can promote independent living and helps an individual. And nowadays we have a lot of senior citizens, even young disabled persons who have to live alone. So we have video magnifiers, computer magnifiers, softwares. We have talking scales, talking glucometers, other devices. I'll just take 2 minutes, sir. So they are image and text readers, they are color identifiers, screen descriptions, tags and labels, voice assistant. So this is a large Macintosh IBM compatible system where you place a piece of paper and it actually magnifies it about 20 times. And you can change color, you can split the full screen and have a look. There are vocalization or synthetic speech system, which if there is something, you put it on that, it will read it out to you. So you will have a small, you can say, earphone. It will talk back to you. So we have job access with speech, magic aid, non-visual desktop access. But this is something which I think will change the game. This is a smart vision device. It has AI in it. It's an artificial intelligence device and we are a part of a team that is piloting it. And here it is actually a small camera that is fitted to the specs and that takes pictures of it and tells the person what it is seeing. So it is like a virtual guide to the blind, helps them navigate. So it can detect the object. So if I was a visually handicapped person and putting this on, it will tell me that, okay, you are in a hall which is about this big. There are about 10 people sitting in front of you. There is a gentleman here with an orange sweater, another gentleman wearing a coat, another lady over here. It can tell their approximate age. It can tell the way they are sitting. So what we see in a glance within a second, in 10 seconds, it feeds in the same information. It can actually store 100 faces. So if there is a blind lady, she knows this is her milkman, this is her watchman, this is her son. So minute they are approaching, they tell that this person is now coming. So it increases safety. So it has a walking assistance, it has facial recognition, it is braille coded, it is a smart vision device. So it's linked to a mobile phone which has a rechargeable battery. And one wonderful thing is it can read in 9 Indian languages. So suppose I go to Tamil Nadu, I can't understand a word of Tamil. It can read a thing in Tamil and it can translate in English or Hindi and tell me what is written over there. So it has so many more, you can say, help. So this new rehab thing is something that all of us ophthalmologists, in our clinics we have patients who cannot now benefit from either surgery or from spectacles or from medical this. So I think it's a duty of all of us to refer them to the nearest low vision and rehabilitation center, because there is so much more that these people can do in their lives. They may not be able to see, but they are still able to live. And I think we ophthalmologists have a very important role to play in this. Thank you. Thank you for giving.